Good afternoon to our Johns Hopkins Biomedical Informatics Data Science and Data Science Grand Rounds. I am Paul Nagy. It's a pleasure to be here. I'm here today with our Grand Round speaker, Dr. Michael Oberst. Michael recently joined us as an assistant professor of computer science at Johns Hopkins University. Michael, when did you join us? It was less than a year ago, right?
Yeah, so last summer, July
Excellent.
1st of last year.
Fantastic. We have a new faculty member who has a research area on safe and effective machine learning in healthcare. She's right at the intersection of computer science and healthcare, using tools for causal inference and statistics. Prior to joining us, he was a postdoctoral researcher at Carnegie Mellon University in the machine learning department, and he obtained his PhD in computer science at Massachusetts Institute of Technology. Michael, thank you so much for coming here today to present to our Informatics Grand Round series. And we're really excited to hear about the work you're doing on studying large language models and how we can use them inside healthcare. Thank you.
Thanks for having me. The title of the talk today is The Data Science of AI and ML Evaluation in Healthcare, Some Pitfalls and Open Challenges. As stated, I'm Michael Oberst, assistant professor here at Hopkins. I'm also a visiting scientist, a part-time visiting scientist at Abridge AI. So I have the following disclosures. As a visiting scientist and sort of paid consultant at Abridge, I have some equity ownership in Abridge AI. I also have, now that's a startup that people may have heard of. I also have some small amount of equity at Clarify Health Solutions, which is probably a startup that no one has heard of, but that's a place that I worked prior to my PhD. So with that, we have some objectives for the presentation today, which are kind of listed here and were also shown previously. And I'm going to talk about these in a lot more detail as we get through it. So with that, we're going to talk about the data science of AI and ML evaluation in healthcare. And the subtitle of this talk is Some Pitfalls and Open Challenges. And the first thing I'm going to do is describe what I mean by that. So of course, when it comes to AI and machine learning in healthcare, we want to make sure we're using things that work. We want to make sure that we're doing rigorous evaluations. Everyone, likes rigorous evaluations, but there are some gaps that exist in terms of how we assess AI and ML systems. And so first part of the talk, I'm going to be talking about what I'd call pitfalls. And this is sometimes in the literature places where we inconsistently apply best practices. And so I'll be talking in particular about accounting for idiosyncrasies in evaluating large language models. And then in the second half of the talk, I'm going to be discussing some work around open challenges. And these are really places where a lot of my work, coming from I think a lot about sort of causal inference and statistics and applications in machine learning and evaluation. There are some areas that are open challenges where we don't necessarily have a well-developed methodological toolkit or best practices to just tell people to do. And so in part one, around pitfalls, I'm going to be talking about this particular vignette, which is some recent work from me and collaborators around medically adapted large language models and vision language models, and asking the question, how much do those sort of quote unquote medically specialized models actually improve over their generic counterparts? And the reason this goes under pitfalls is because there's an impression you might get from reading some of this literature, but in our work, we show that the gains sort of appear marginal upon re-examination after accounting for some methodological pitfalls as we see them. In the second part on open challenges, I'm going to be talking about a slightly different topic. So not focused sort of exclusively or specifically on large language models, but thinking about a broader question that comes up a lot in evaluating AI and ML in healthcare, which is how we evaluate the impact of deploying these systems on outcomes for patients. And a particularly salient question that comes up quite a bit, which is how we think about ongoing reevaluation of impact, especially as we update our machine learning models. So I'll be discussing why this is an open challenge and also some new kind of statistical tools and frameworks for assessing the impact of model updates using historical RCT data without the need for running entirely new trials. So with that, I'm going to get into the first part. The two parts, and credit where credit is due, are based on papers where I want to highlight the first author on each of those papers. So this first set is actually going to be a pair of papers, an EMNLP paper, and then some follow-on work, all done by Daniel Zhang, who's a PhD student at Carnegie Mellon University. And this part 2 on open challenges and evaluating causal impact is work that was led by Jacob Chen, who's a PhD student here at Hopkins in the computer science department. And so with that, I'm going to get into this first bit, which is medical adaptation of large language models and vision language models. Are we making progress? As with any title that ends in a question, you can probably guess the perspective just from reading the title. But we're going to go through that in a bit more detail. But before I go through what we do in our work, I want to sort of lay out some context. There's a general hope that people have, an ambition, if you will, for large language models and vision language models in medicine and in healthcare more broadly, which is this idea of having some kind of base model like a ChatGPT, but for healthcare, that can handle a lot of different sorts of tasks, given a common model and given some context. So given, for instance, visual context like chest x-rays or natural language context like clinical notes, you might hope to get some system that is able to handle a lot of different tasks. So you may have input queries that are about a medical diagnosis and hope that it gives you some reasonable diagnostic answer out, given the context you've provided it. You may have more information retrieval style questions, for instance, trying to summarize past clinical history for a patient. Or you may have other questions, such as around patient triaging, asking, hey, is there anything just abnormal about this scan in the context of the patient's history that I should be aware of? Now, this is the vision of some general purpose technology that works well for answering healthcare questions. And so there's a lot of interest in this area. I probably don't have to kind of convince this audience of that. Whether it's in academic research or in people deploying systems like open evidence being a popular one, which is explicitly trying to do this, right? Ask and answer, be able to answer medical questions. But of course, there's also interest in applying these sorts of models to many other areas, whether it's clinical trial patient matching or co-pilots for human pathologists or radiologists, et cetera. Now, a challenge, at least conceptually a challenge that you might worry about, is that a lot of the models that exist, if you think about interacting with ChatGPT or other models, they're not sort of developed specifically with the medical domain in mind. And even if you think just about the natural language processing and the understanding of clinical notes, for instance, you might reasonably think some domain knowledge is required. So this is one of my favorite examples of this. Credit here goes to Monica Agarwal, who is an assistant professor at Duke and a former PhD lab mate of mine. So this is sort of shamelessly taken from some of her slides. But we have this string of text. We wish to understand it. Well, the first step in understanding it, we have to understand what these acronyms and abbreviations stand for. And even if we filter down to abbreviations that are plausible in a clinical context, such as the ones that I'm showing here, it's not immediately obvious, unless we have some domain knowledge, what to pick out, how to interpret this sentence, where a correct interpretation might be something like this says, patient given carboplatin intraarterial for triple negative breast cancer will discontinue. And so motivated by this concern that it may be worthwhile to try and imbue more sort of medical knowledge into sort of off the shelf, what I'm going to call general domain, large language models and vision language models. People have pursued this strategy, one of many possible strategies. This particular strategy is called domain adaptive pre-training, and that's going to be the focus of what I talk about today. So how does this work? Well, generally the way that this works is you take some general domain model, and these are all going to be models for which you can get access to the underlying model weights themselves and actually do some modification of the model. So this would be models released by Meta, like Llama 3, or models released by other companies like Mistral, open source models. OpenAI now has an open source model that you can play around with, or I should say open weight model, in that you can get access to the weights. And you want to make some modification to those weights. And a general strategy people pursue, this is domain adaptive pre-training, is they will, they don't have any particular medical task in mind. They are trying to, again, get some general purpose model that can answer lots of different types of questions. And so what they will do is they will take some corpus of medical text and images, such as going through PubMed to find figures and captions, or going through CDC guidelines, et cetera, et cetera. And an example of what they'll do in this framework is they will take that data set and they will have some other, very capable model generate sort of potential question answer pairs based on, say, a caption of an image. And then they will train the model that they started with to be able to answer those questions. So train it to produce answers to, say, questions about images in PubMed articles. And then having done some, I'm putting medical in quotes in a lot of these places, having ostensibly done some medical specialization, they now bless the model as a medical model. So typically this will have bio in the name or med in the name in some way. And to give a specific example, and this is a vision language model, so a model designed to take inputs like both images, say chest x-rays, and text like questions and be able to produce reasonable answers. One such model that has been released is from Microsoft. It's called LavaMed. And it's called LavaMed because the model they started with was a model called Lava. And that model is trained to answer questions about normal images that you might find on the internet. And so what they did to kind of specialize this model for the medical domain is something similar to what I just described. So they created some illustrative question-answer pairs based on PubMed data, and then they tuned the model to be able to answer those questions well. And then they have as output some model LavaMed, which both has med in the name, has a little lab coat on, and is ostensibly some medically specialized version of Lava. Now, this has become common practice. I've given one example, and I sort of highlighted some others on the previous slide. And in the paper that I'm about to describe, we benchmark a variety of these, and this is a table from that paper, where we're looking at a variety, each row here is a different medically specialized model, where we're showing both the general domain model that they started with, that they used as their base, like Lava in the example I just showed, and then done some adaptation on some medical corpus of text and images to get some medical domain model. And we evaluate in this paper both pure language models, that's the LLMs here, and those sort of vision language models shown at the bottom. And these medical adaptation corpora that people use, largely speaking, though not exclusively, are like what I just described. So PubMed articles or medical licensing exam questions are used to sort of further tune the model to try and get to a base model that is more adapted to the medical domain. And to understand why people have been excited about this approach, why there are so many papers, like I just described, taking this approach, is because their prior work has suggested some gains to be had from following this procedure. So I'm showing here a figure from Metatron, which is one of these papers, where they show on a couple of question answering data sets, some of which are more US medical licensing exam style questions, other ones derived from PubMed. They show, look, this is the accuracy of our model in blue. And note that our model only has 70 billion parameters. Now that's a big number, but it is small in comparison to some of the other models that they benchmark against, like MedPalm and MedPalm 2 from Google, both of which have 540 billion parameters. And they show, look, we can get performance that's not always as good as those models, but somewhat comparable. And the thing they're really excited about is, hey, look, GPT 3.5, don't know the exact parameter count for that model, but it's certainly rumored to be a lot more than 70 billion parameters. We're doing much better than GPT 3.5. And these are papers that were coming out late 2023 at a time when GPT 3.5 had made a big splash with ChatGPT, and this was sort of viewed as the thing to beat. So, in our work, we sort of revisit this question of, does medical domain adaptive pre-training improve performance on medical tasks? And our finding is that the gains are more marginal than you'd expect. But first, because this is about pitfalls of evaluation and sort of methods for doing this sort of benchmarking, it's worth talking through how you might go about answering that question rigorously from kind of first principles. And so one way to think about this is we really want to isolate the impact of just that one step, that domain adaptive pre-training. And we want to understand, does it lead to a model with more medical capabilities than the sort of base model that something has been developed from? So one thing that we would like to do to sort of isolate that impact is do head-to-head comparisons. So in the chart that I just showed you, I didn't show you the model that Metatron 70 billion was developed from. I just showed you other models like GPT 3.5, et cetera, et cetera. But if we really want to understand the impact of this procedure, we need to do head-to-head comparisons of the base model versus their quote-unquote medical counterpart. And perhaps equally important, and this is going to be a big theme of this part of the talk, is accounting for prompting sensitivity. So as I will try and illustrate to you later on, many of these models, at least the models we consider, so these are 7 billion parameter up to 70 billion parameter models, are extremely sensitive to even the formatting of the prompt that you use. And so you need to kind of think about some way, and we have one way here, but you can think of others, some way to account for prompting sensitivity to make sure you're doing a real apples to apples comparison of model capabilities. And I'll talk about how we do that in a moment. And then the third thing that you might reasonably want to do is incorporate some sense of statistical uncertainty. So in particular, as I'll show you in a moment, many of the data sets that are used for evaluation of these models are quite small. And so some difference in performance may not be sort of statistically significant, especially when, for some of these models, for instance, the test data set is only 25 questions, and you're just counting fraction that you got correct. So that's what we set out to do. We set out to do all three of those things. And I'm going to talk about kind of the two axes of types of tasks that we consider and use cases for medical LLMs and VLMs that we consider. And now this is a combined view from both an initial paper that we had back in 2024 and a more recent preprint that sort of has been updated to include a lot more evaluations. So first, on the type of QA tasks, the first type of QA task we consider are really these medical knowledge QA or kind of similar style of questions for visual question answering. And a canonical example of what I mean when I talk about medical question answering in this context is multiple choice questions typically drawn, though not exclusively drawn, from medical licensing exams. So for instance, we have a question here with some context. We then have the context, we have the question in green, which of the following is the most likely cause for the patient's symptoms. And then we have multiple choice answers, and the model is going to be evaluated on the basis of whether or not it picked the right answer out of the multiple choices. So there are a variety of these types of questions. Some of these are viewed as more some of these are a bit more like medical licensing exams. Some of them are derived from PubMed. Others are derived from other sorts of exams, like on biology and genetics and so on and so forth. But they all have that style of kind of quizzing you about medical knowledge. And then for vision language models, we have a variety of visual and medical QA questions, including answering questions about radiology scans or pathology slides, along with some other questions that involve looking at figures and answering questions about the figure. And this is where I said before, some of these data sets, if you look at the test set column, that's the evaluation set that's used, oftentimes the test set is actually quite small. Now, a third type of category, maybe a little bit closer to actual clinical use of these models, is to answer questions about clinical notes. And so an illustrative task in that context is something like EHR Note QA. So this is not a data set that we constructed. This is this wonderful resource from some researchers in South Korea, where what they did is they took a data set called Mimic4, which contains a lot of discharge summaries that are available under a sort of data use agreement. They used that, passing it into some capable large language model to generate candidate multiple choice questions and answers. And then to make sure that this was an actually good, useful resource, they had clinicians review, make edits, sometimes change the questions, et cetera, in order to get to a sort of high quality data set of note QA questions. So an example after kind of clinician edits to make it sort of precise and clearly answerable. We have a question like, given a context like clinical notes, what are the major health issues documented during the patient's initial admission? What was the primary surgical procedure performed? We're answering questions about notes, but it's still multiple choice questions. So the benefit of this is we have some very clean way of evaluating whether or not it gets the question right or wrong. Now, there are a variety of other data sets that we consider when we think about benchmarking models on what we're sort of calling clinical note QA. Some of these are more that type of clinical note question answering. Others are more traditional natural language processing tasks, like natural language entailment and so forth. So those are the types of tasks that we benchmark against. And then I'm going to talk about amount of task-specific training, because there are a couple of different use cases you could imagine for using these models. We want to make sure that we cover all of the sort of potential use cases. Now, the most obvious one is what people would, in the sort of language model literature, would refer to as zero-shot prompting. And this is probably what you imagined when you first heard about evaluating models along these lines. It is just providing as a prompt the question itself, a little bit of instruction, answer by choosing one of the options from A to D, and then you get some answer out and you check to see if it produced the correct result. Then a variant of that, which is called few-shot prompting, involves providing a little bit more information about the task to the model in the form of other example question-answer pairs from, say, the training data set, if you will. So for instance, you might say, hey, here's an example of a different question and the sort of answer I wanted. You could do this with one example. You could do it with 3 or 5 or a couple more in order to hopefully guide the model towards understanding the kind of context that you're in and the types of answers that you're looking for. Now, on the other extreme, what you could also do is you could use these models as some new base model to do some further task-specific fine-tuning. And so that looks something like taking your questions, getting answers from the models you start with. So this would be like the clinical model, comparing that answer against the ground truth, and then doing further updating of the model weights themselves in order to make the model better at your specific task, like answering medical licensing exam questions. And so with that, those are kind of the two axes that we evaluate along, and I'm going to be talking about them a bit more in the subsequent slides when I talk about results. As far as the colors go, you can sort of ignore the background color here. This is just distinguishing between the sort of original work that we had and sort of more recent work where we extend it and look at more evaluations. The blue triangles are settings that had been evaluated previously in the literature, and the sort of red stars are sort of net new settings and models benchmarked in our work. So the models are old models, but evaluation on these particular tasks is sort of new. So again, returning to how we do this comparison, the first thing you'd like to do is compare head to head. And so I showed you that some of these evaluations have already been done in the literature. And if my message is going to be one where they don't look as promising as we thought, you're going to reasonably ask, well, how does your evaluation differ compared to other people's evaluation? And one thing that's notable, though it's not the main thing, is that it's not always consistently the case that people do this kind of head-to-head evaluation. So in particular, not all comparisons are truly head-to-head. They are in many cases. So there's green check marks or some of these papers that we are sort of replicating and benchmarking their models. In a few of them, they actually don't compare to their base model. Now, I talked about Metatron before. I showed one figure from the Metatron paper. It is the case that later on in the Metatron paper, they compare to their base model, but that's not sort of universally true for everyone. So for instance, Clinical Camel is one of these models where it is compared to GPT 3.5 and 4, but it's not directly compared to Llama 2, which is the model that it was derived from. But this second piece is, in our view, where a lot of evaluations fall short. And I'm going to talk about this in a little bit more detail now, which is this idea of accounting for prompting sensitivity. So here, the idea is you want to make sure that your two models you're comparing head to head, the base model and the medical model, are both able to do as well as they possibly can. But more broadly, you want to make sure that you're not unfairly advantaging one model over the other. So for instance, you could imagine there being some implicit research degrees of freedom where you develop a medical model, you try and get it to work on question answering, you realize you need to tweak the prompt a bit to make it work a little bit better. And now you have something that seems to work reasonably well for your model you just developed. You do your head-to-head evaluation where you use the exact same prompt for both. That can lead to misleading results, as we'll sort of argue. And so if you look at sort of some version of accounting for prompting sensitivity, this is something that broadly speaking is not often explicitly accounted for, even when doing head-to-head evaluations. So these NAs are cases where there wasn't a head-to-head evaluation in the first place. And the X's are there's sort of no accounting for prompt sensitivity. And the orange triangle are cases where they did a little bit of this by playing with sort of what few shot examples they used, but they didn't do any other sort of searching over prompts to see how sensitive the results are to the choice of prompt. And then the third angle, incorporating statistical uncertainty, as is in the case, frankly, with a lot of machine learning papers. I say this as someone who works in machine learning. It is often the case that people don't report error bars or test for statistical significance, which maybe is okay when your evaluation set is 100,000 images, and those error bars would be very small anyway. But when your evaluation set is 25 questions, it starts to make a lot more sense to do some statistical testing. So in our approach, we do all three of these things. And what I'm going to talk about next is kind of the difference that that makes. So after doing all of that, what we kind of compute is we compute something on a per data set basis. So basically on a per task basis, we compare the medical model against its base model, and we look at the difference in performance on that particular test. And this is all some sort of held out test set. And then what we're showing on the y-axis is the proportion of those evaluations across all the model pairs and QA data sets that we consider. We show the percentage of combinations where either the medical model wins, defined as having a statistically significant improvement in accuracy or whatever the relevant metric is. We show the fraction of cases where there is a statistical tie that is not a significant difference. And we show the percentage of cases where, in fact, the base model under our evaluation setup, where we kind of tune prompts independently for each model, we actually see that the medical model loses more often, loses compared to the base model. And so, in fact, under our evaluation, medical models lose more often than they win across all three of these types of tasks in zero-shot evaluation, and the same story holds in these sort of three-shot or few-shot evaluations. So, prompting sensitivity. An observation that we make is that prompt optimization makes a huge difference. Now, this is not a net new observation. People have known this about language models, but it's worth incorporating at least somehow into your evaluation setup. And so to illustrate, what I'm showing you here is a particular model. So this is clinical camel 70B, that means 70 billion parameters, against llama 2 70B, so the base model it was derived from, on those medical QA tasks under the sort of three-shot evaluation, just to pull out one example. And what we see here is that if you put yourself in the shoes of a researcher who maybe inadvertently chose a prompt that happened to work really well for your particular model, that is the medical model, which we kind of replicate as a proxy by actually optimizing the prompt for the medical model and then using the same prompt for both models in the evaluation, we see that under that setup, the medical model wins a majority of the time and the rest of the time are ties. Now, on the flip side, if you do what we did, and to try and make an apples to apples comparison, use a little bit of validation data to tune the prompts for both, that's what we're calling independently optimized, you end up with a very different picture. So these results are very sensitive to the sorts of prompts used. I'm going to give some examples in a moment just to show you how small the differences can be to make a big difference like this in the evaluation. But first, I'm going to talk a little bit about what do I mean by prompt optimization. And if you're familiar with machine learning in general, you can think of this as hyperparameter optimization using some validation data set, where there are lots of choices that you have to make around prompt design in terms of the format, in terms of the examples you use if you're using few-shot prompting. And if you're doing supervised fine-tuning, which we'll also talk about later on, of course, you have lots of hyperparameters like the learning rate or the dimension of your sort of low rank updates, et cetera. And so treating this as a hyperparameter optimization problem, just to, again, get to sort of a comparable head-to-head evaluation where both things are performing kind of as well as they can, what we do is we sample different prompt formats, we sample different sets of few-shot examples, and we use validation data to pick independently for each model, the medical versus the base model, the best format and the best examples. Now we have some way of sampling different types of prompts. I'm not going to get into the details of it too much. This is actually an approach that we borrowed from some other paper that had sort of introduced this grammar of sampling different prompts for other sorts of tasks. But I wanted to get to a concrete example of what I mean by two different prompts and a prompt that is optimized for one model versus another. And the takeaway, if you didn't follow any of the rest of it, is this. It's that for this particular comparison between Clinical Camel 7dB and Llama 2 7dB on a particular clinical knowledge task, we have that the optimal format for Clinical Camel looks like this. The only difference between these two things is the formatting. So for Clinical Camel, it's star star question star star equals, and then the question, and then star star answer star star equals, and that's where it's supposed to put its answer. If you use that prompt, or similarly a prompt optimized for Clinical Camel, and you use the same prompt for Llama 2 7dB, and you do your head-to-head evaluation, things look very good for Clinical Camel because you picked a prompt that works well for Clinical Camel. If instead you give Llama 2 a prompt that, at least empirically, it does a lot better with, which is pound, pound, pound question and pound, pound, pound answer at the end, now you get results like what we showed, where in fact, Llama 2 tends to do better in most cases than Clinical Camel. So that's accounting for prompting sensitivity. Those results are not specific to Clinical Camel. In general, though it may be one of the more stark examples, in general, when we compare optimizing just for the medical model versus optimizing for both, we see this big drop-off, where empirically kind of the best prompt for the base model is often slightly different than the best prompt for the medical model. Now I have some other results going to the weeds. I'm going to go through these a little bit more quickly, just in the interest of time. But one thing that we observe, if we kind of dig into the details a bit, is I was just showing you aggregate results across all of these different models, across all of these different tasks, and you could absolutely dig in and say, okay, but what about, are there specific models that seem to be doing really well? Maybe there's one model that's winning all the time, and then it's the other models that are kind of dragging down this approach and evaluation. We don't really see that. And so there are some specific combinations of task and prompting type, et cetera, and model where you see wins for the medical version of the model, but these wins are kind of inconsistent, broadly speaking. There is, for instance, only one model that consistently improves upon its base model, and that's a model where both the base and the adapted model have very poor absolute performance. So it's starting from a very low baseline and manages to improve a little bit. Similarly, if we look at clinical note QA, so this is another example of a task. I was just showing you medical QA. We have only one model that outperforms in both settings, but somewhat confusingly, it is Med42 V1, whereas Med42 V2 does not improve over its base model. And so, full results you can find in the papers that I'm sort of linking. So medical models lose more often than they win, at least on these zero-shot and few-shot evaluations. Part of our motivation for extending our initial work was to look as well at fine-tuning, where it does seem like there might be some promise from this domain adaptive pre-training approach, but specifically perhaps on these medical knowledge QA tasks. So we don't really see any lift when it comes to clinical note QA or visual medical QA, but it does seem like there might be some improvement as serving as that initialization for downstream fine-tuning on medical knowledge QA. So takeaways. A lot of energy has gone into this medical adaptation of open weight models. We find that the empirical benefits of this approach are a little unclear in retrospect under an evaluation that accounts for certain things, with the exception maybe of supervised fine-tuning on medical QA tasks. And we identified sort of a few important considerations, and this was the pitfalls part, right? You really want to do head-to-head evaluations if you're going to be making a claim like domain adaptive pre-training is a great tool. You want to do something to account for prompt sensitivity. I'm open to other ideas from the audience if folks have any. The way we chose to approach it was to optimize sort of prompts independently for each model to ensure we're sort of getting the best out of both, really testing the capabilities of each model, and of course, incorporate statistical uncertainty. So that's that first part of the talk. We're going to reserve questions for the end. If you have questions on that first part, please do put them in the Q&A. But I'm going to move on to this second piece, which is around open challenges. And this is going to be a bit of a different topic. I'm going to be motivating this less with large language models or things of that nature, and more with what you might think of as classical decision support tools in a medical context, like some alerting system that raises alerts for patients that it suspects are sort of on a downward trajectory, degradation detection, sepsis alerting models, that sort of thing, or more traditional supervised learning models that are providing some discrete diagnostic output. So the title of this work is about ongoing causal validation of machine learning models. And so I want to recap or just ground us for a bit, like what am I talking about when I talk about causal validation? Well, the way that we're using that term can be motivated sort of as follows. If you think of something like, say, a sepsis alerting model, that is looking at patients, it's processing their information, and then it has some output. Maybe it's an alert, as shown here, or no alert if it thinks the patient is low risk and doesn't need to be alerted on. So our model produces some output based on information, but then we hope that some decision maker is actually looking at that output and maybe taking an appropriate action based on the output, their own clinical knowledge, et cetera. So in the case of sepsis, this might be something like you see an alert, and maybe that leads a clinician to initiate the relevant bundle treatment to try and address the issue. And then we observe outcomes in our data. But these are not outcomes we were predicting necessarily. This is just, do the patients survive when we deploy this sort of system? And in particular, do they survive more often than if we hadn't deployed a system like this? And so when we talk about causal impact, that's how I'm using the term. It is the impact of deploying some AI assistance on outcomes of interest, like patient outcomes or whatever else might be of interest as an endpoint. Now, this is a general problem beyond healthcare. Of course, there are lots of places where we think about deploying AI systems to assist decision makers, but for our purposes, we can just talk about sort of the hospital context. And there is kind of a clear, I haven't really gotten to the open challenge yet, because we do have tools to evaluate causal impact. In particular, we have randomized control trials. So for instance, when evaluating a system like a machine learning system, some sort of AI assistance, if you want to call it that, for clinicians, we have a framework for doing that evaluation. And that evaluation looks like taking either individual clinicians or entire sort of wards or clinics or health systems in some cases, taking a large group of those and randomizing them. As in a randomized trial, some, say, clinicians get access to the tool, some clinicians are randomized to not get access to the tool, and then at the end of the trial, we compare some outcome. So this could be something like survival, it could be some other clinical endpoint that is of interest to the trialist. And what we hope to see, regardless of what that outcome is, assuming that higher is better, you can think of this as something like survival rate, though obviously these are highly made up numbers. We hope to see that, okay, in the arm where we deployed the model, we got some better outcome for patients. Now, of course, one thing that you could also do is you could design a randomized trial where you have multiple arms. And in particular, you could have a cluster RCT where you trial multiple models. And for instance, see that maybe one model improves outcomes, but one model does not improve outcomes and may even lead to harm. For instance, if clinicians are so bogged down by all the false alarms they're getting that they are not able to take care of patients as well. Now, again, entirely made up numbers, just a cartoon to illustrate the concepts. So there are real trials that happen along these lines. People say we need more clinical trials of machine learning models. I agree, but we do have some trials that have been done on various sorts of systems. So this is an example of a trial for improving antibiotic prescriptions with model-driven best practice alerts based on predicted risk of resistance to various antibiotics. This is not my work. This is just an example of a randomized trial that is out there, where again, points I want to make, this is a large-scale endeavor, running a clinical trial like this. This one involved randomizing 59 individual hospitals to treatment and control arms. But the goal is to build some rigorous evidence for what's the impact of deploying this system on outcomes. Now, randomized trials are great, but they have an important limitation, which is pretty obvious once you think about it, which is that they only tell us something about the specific machine learning systems that we deployed in the trial. And again, running a trial is often a very complex and time-intensive endeavor. And so, of course, we can't expect out of the box, and this is where the open challenge arises, certainly without any further assumptions, that they don't tell us anything about the impact of some other model. Now, why might we be interested in some other model? Well, a common scenario that arises is you run some giant randomized trial, you validate that your machine learning system actually does genuinely improve outcomes or perform pretty well. But now you have a bit of a conundrum because you've gotten new data, maybe you've deployed some places and you've collected a lot of valuable feedback, and now you would like to update your model. And you think you genuinely have a better model than the one you had before, but this is not the model that was in the randomized trial. So how do you answer people who ask you, well, how do you know that this new model has sort of the desired impact on patient outcomes? And that's the question we're going to be trying to answer today from more of a statistical methods perspective. And so our goal, and this is the kind of framework that we operate under, if you're just trying to understand inputs and outputs, like I'm proposing a method to do something, what is that thing? It's something like the following. Given data just from a randomized trial that compared a couple of models, what we're going to be doing is we're going to be combining that data with some assumptions, and these are going to be sort of statistical causal inference style assumptions. So as I'll describe, many of these assumptions are checkable using appropriate RCT data, and I'll explain what I mean by that. And so given those two components, what we would like to be able to do, and what our framework sort of provides, is some way of estimating or putting upper and lower bounds on the causal effect of deploying some new model. So this is one that wasn't included in the trial, but where we would hope to get some reassurance like, okay, we have some model updates. What can we say about its impact on outcomes? Well, maybe we can't exactly say what we think its impact would be, but we can at least convince ourselves that this is safe to deploy because the lower bound on its, say, expected survival rate of patients when using this model is higher than what was in the control arm of the trial. So something like that. So how do we get there? I'm going to spend a bit of time talking about that, though if you take away nothing aside from inputs and outputs, that's also very reasonable. But I do want to illustrate why this is a challenging problem, beyond the obvious fact that we just don't have data from the new model. So one extra bit that makes this challenging is the issue of trust, and the second issue is the issue of coverage. So one place you might start if you were thinking about this from kind of first principles is you might say, okay, I have some model, it has some output, that's the model that was in the trial, and then based on that output, the impact that it has on patient outcomes is not directly a function of that output, it's some function of what the clinician does in response to that output. So if a clinician sees the output and says, oh, there's an alert, I should take action, maybe that leads to a positive outcome for the patient. And so now you have some new model. And your first thought might be, well, at least when the new model gives the same outputs as the old model, maybe I can expect that outcomes will be the same. Maybe that's sort of a shortcut that I can take. One challenge with that, and one reason why that might not be a reasonable assumption, is that you might have, for instance, a model that has a high rate of false alarms. So say your old model, Model 1, raises alerts on this type of elderly patient. Your new model, Model 3, also raises alerts on this type of patient. But what you don't realize is that Model 3 also raises alerts on literally every patient. And if that's the case, you can imagine the clinician is going to act differently in response to the model outputs. And so as a result, even if you are looking at, say, a particular population of patients where they're the same type of patient and you have the same model outputs, you might sort of reasonably think that outputs could differ based on perceived model reliability and performance. And so that's something you want to take into account if you try and do what I'm describing, which is estimate the impact of some new model. And the second challenge is that you may, for instance, just not have data on certain things that are of interest to you. So your new model might raise alerts, say on these cartoons of younger male patients, whereas in the trial you had a control arm and you had these other two models, but none of those arms involved raising alerts on this type of patient. Now, if you run into that, you have a more serious problem potentially, which is that we can't really infer the outcomes of actions that we've never seen for particular types of patients. And so that's the challenge of coverage. Now, the way in which we sort of model those challenges and try and address them involves some assumptions and some sort of causal modeling. I'm going to try and walk through that at a high level without getting into too much of the weeds. But we start with this sort of assumption around how the data generating process works. So the story for kind of how the world works, and I'm going to explain this in little pictures instead of just in the notation that we've got down here. So in the trial, at least, the model that's being used, say the first model, is randomized, right? The model that gets used for you is some randomized quantity. And so that's pi, and pi represents the deployed model, or equivalently, you could say the alerting policy, if you think about, say, alerting systems. And then x just denotes what we know about the patient. These are the inputs to the, say, alerting system in that example. And then A is, you could think of it as the alert, you could think of it as the action, sort of taken the output of the model, where typically these outputs are deterministic. And that's what gives rise to that coverage problem that I just described. It is typically the case, at least as far as I can tell, that people are, when they deploy, say, some alerting system, they are not throwing the statisticians a favor and saying, you know, good news, we're going to have the alerting system flip a coin for each patient, and sometimes, maybe 5% of the time, randomly decide to throw an alert or not. That is not something you generally want to do if you're deploying a real system, because you want people to be able to trust the outputs. But as a result, it does create challenges on the sort of the challenge, the task that I'm talking about, the fact that model alerts tend to be deterministic. And that's something we account for in our framework. Then, and this is really the big assumption, we assume, sort of to make progress and to illustrate how you might tackle this problem, that there exists some computable metric that captures sort of overall model performance and trust. So this could be something like the false alarm rate, or it could be a couple of metrics that you've kind of condensed via some combination into a single metric of performance. And the idea that this is a good proxy for how much clinicians are likely to trust a given model. And then, of course, the outcomes for patients are both a function of information about the patients themselves, as well as the outputs of the model, as well as the model performance in general, because that impacts the extent to which clinicians trust and sort of take action based on the model outputs. So with that, our goal is to bound sort of the outcomes for new patients under some new model. And I'm going to describe now, hopefully briefly, so we have time for more questions, the types of assumptions that we kind of make in this framework. I hope you'll think they're somewhat reasonable assumptions, but I'm also going to talk about ways in which you can sort of sanity check these assumptions. So the first assumption we make to try and tackle this issue of trust is to assume that the outcomes for patients, if I have two models that both produce the same output, like I had in my previous slide, and if those two models have different performance metrics, say different true positive rates, or, you know, where higher performance is better, if one of them, say, has a lower false alarm rate, we assume that the outcomes under the model with the better performance are at least as good as the model with worse performance. And that's sort of what this assumption is sort of embedding in more kind of mathematical notation. Now, the nice thing about this assumption is that if you do a randomized trial where you trial more than one model, you can actually check to see if this assumption holds, at least in your trial data. You can never prove that it holds all the time for all possible models, but you can at least sanity check it in what's called a falsification test. So for instance, if I have some trial where on the x-axis I'm showing risk scores, and I'm showing two different models, and these models only differ in terms of what threshold they use to raise alerts. What I'm showing on the far left then are patients with very low risk scores, where neither model raises an alert. in this sort of middle area, I'm showing a set of patients where the risk scores are between T1 and T2. And so model 1 is raising alerts. That's the triangle, but model 2 is not. And then above T2, I have both models are raising alerts on this patient population. And what this assumption implies is that if model 2 has better performance, like it's raising fewer false alarms, then if this assumption is true, what you should expect to see is something like this, where the outcomes in that purple box are on average better for model 2 than model 1. So you'd say, okay, this assumption is at least consistent with the data I got in the trial. But if you saw the reverse, you would at least have some warning sign that this assumption that I have proposed is unrealistic in your application. Similarly, we have an assumption around what we call neutral actions, that there are some actions or some outputs of models for which performance kind of doesn't come into play. The idea here, and the reason we talk about this, is that you often have a control arm in your trial, an arm where no ML was deployed at all. And if you want to use that data to learn something about the impact of new models, you have to make some assumption that allows you to make use of that data. So in that context, the assumption here would be that if I have a new model that's not raising alerts on a particular part of the population, that maybe I can look at outcomes for those types of patients in the control arm of the trial, where also obviously no alerts were raised. Now, the nice thing about this assumption is that you can also check it in an RCT to see if it at least holds in that context. So for instance, in my previous example, you can look at this part of the patient population where neither model is raising alerts. And this assumption suggests that the average outcome should be the same for both models. If you do a statistical test and you find that's not true, that gives you some evidence to say, this assumption is maybe not realistic in my particular application. But given those two assumptions, we have a third and final assumption, which is, let's say, a lot easier to justify. So for instance, if outcomes are binary, like survival or no survival, this and y is therefore 0 or 1, this holds kind of by definition. Just that there is some worst case scenario, which is, for instance, that patients, if you're talking about mortality, worst case scenario would be full mortality for lots of people where you don't know what the right answer is. And the best case would be, say, everyone survives. But there's some boundedness to our outcomes. And so if you put all three of these together, we now have the assumptions piece, and then we have some way of estimating the causal effect of deploying a new model. And in the interests of time, I'm going to go through this a little bit, maybe more briefly. I think I'll just sort of skip some last thing that I had at the end to make sure we have time for questions. But the idea of how you construct bounds in this context is actually pretty simple. So essentially what you do is for each type of patient, you consider the outputs of the new model, and then you basically ask, based on my assumptions, how can I construct, say, a lower bound on outcomes under the new model? And so, for instance, if you're in the neutral action regime, so you have a model that's not raising alerts, then all you have to do is you have to find some data you have in your trial where alerts were not raised on this type of patient, and then you can use that to sort of infer what might have happened under deploying your new model, at least for that particular type of patient. But of course, if you find yourself in a situation which you just don't have any data, for instance, you did a trial with no control arm and all of the models you trialed raised alerts for this type of patient, then in our approach, you'd be very conservative and say, well, I don't know what could happen. So the worst case is that raising alerts or not raising alerts on this particular type of patient leads to very bad outcomes for everyone. Now, conversely, if you have some non-neutral action, you want to incorporate this notion of bounds using performance metrics. And so here you'd say, well, if I'm raising alerts for this patient, I need there to be someone in the trial who also raised alerts for this patient and whose, say, false alarm rate was about the same or maybe a bit worse than my false alarm rate, so that I can use their outcomes as a lower bound on my outcomes. And similarly, if there's just no one who meets that criteria, you'd be conservative. There's a lot of math in the paper that tries to sort of put that in a more formal way, but you're welcome to look at the paper for more details. And we have some other kind of results here. We show that these bounds are tight in the sense they can't be improved without more assumptions. We have some estimators that give you confidence intervals. But the intuition here, as you might expect, is that the more similar your new model is to the ones in the trial, the tighter these bounds will be. And you can get bounds for any model, but if the model is very different and is taking all sorts of actions you've never seen, the bounds are going to be very wide. And so we have a little sort of simulation study. This is not real data, but I think for in the interests of being able to get to some QA stuff, I'm going to sort of skip through this and just sort of leave it at this summary of this part, which is we have some way of estimating or bounding the impact of a new model. There are assumptions. Some of those assumptions are falsifiable. One implication of this is if you are considering running a randomized trial of an ML system, it is worth your time potentially to trial multiple models in the original RCT. And hopefully this is sort of a first step towards rigorous and reliable reuse of RCT data from ML deployments. And so with that, I'm going to keep this slide up, and I would love to take questions. And also, if anyone wants to email me questions, if I don't get to your questions, my email is moberst@jhu.edu. Please feel free to reach out.
Thanks, Michael. So you have a couple of questions here, and they still seem to be rolling in, but we'll try and get to a couple before the end of time here. The first one, which I think is pretty interesting, is the topic of bias. So bias in particular in the training data or the fine-tuning data. And
Yeah.
Robert was asking about whether a bias of publications that these might be trained on being tended towards significant results as opposed to insignificant results, and does that cause these models to look for more abnormal, he calls it, look for
I think
zebras?
it's a good question,
Yeah.
Especially in a context where people make a lot out of the sort of New England Journal case studies style evaluation. You have some very complicated patient. Are you able to get to the right answer? I think in this context, it's not entirely clear to me how that would maybe skew the particular evaluations considered here. Like a lot of the evaluations considered here are things like medical license exams, where like maybe the problem is that that's actually not necessarily the right benchmark for LLMs, but that might be a benchmark that you might expect to be more aligned to the sort of stuff you'd see in the sort of looking for zebras.
Day in and yeah,
But
and they don't always cover day in and day out type clinical
Yeah.
questions that you would expect someone to.
Exactly. That's the other thing
that's
that's funny about using PubMed is there's a lot of stuff on PubMed that is less relevant for clinical question answering. I would say briefly just that, this is one approach to fine tuning that tends to use a particular type of data for a particular task that you have in mind. This approach might work very well as long as you are curating data that's relevant to your task and sort of using that to kind of update your model. But
this I'll just extend this question a little bit. Is the medical domain too broad for fine tuning? Do we need a like specialty level LLM trained? My experience is in radiology and imaging. For these like vision language models, do we need to train them on specifically radiological information and not train them on such large corpuses and maybe look towards boarding exams rather than licensure?
yeah, no, I think that's a great point in general when I talk to people about this sort of thing. I mean, another example that comes up, and part of the reason we had sort of clinical note QA as an example here, is that there's a big difference even between I have a model that has a lot of like biomedical knowledge, quote unquote, from looking at PubMed versus I have a model that has seen clinical notes and sort of like understands implicitly the clinical notes. And that's not even a specialty specific question. That's more of a
yeah, it's just almost a formatting and design problem.
Yeah.
And then a lot of these questions are pointed towards your work about the prompt specificity and the prompt sensitivity. But I'll just extract a couple of things. Asking about things like an ensemble approach or other things that might get past some of these sensitivity pieces, is there anything that you've seen that would make these models perhaps less sensitive, or you would know when your prompt is optimized well enough?
Yeah, it's a good question. I was sort of skimming some of these as well. I think there's sort of two points of view you can have on this. Like if you are trying to make something that works generally, you don't really have a specific task in mind. You could say like, I want some robustness to the prompt format. And so maybe I want to do something like on the back end, tweak the prompt a few ways that are not semantically different. As noted, like the things that I showed are not changing the semantic meaning of the question, it's just formatting. And you can do things like ensemble the results or do kind of a majority vote of results and hope that that is going to at least make things more stable in terms of sensitivity to sort of particular formats. The other thing you can do is if you have a particular problem, maybe you do want to do a bit of playing around with different formats to get good performance in your domain, but that supposes you have some way of measuring performance that's sort of clear cut and you have a particular task. The other thing I'll say is it's not entirely obvious to me that the extreme prompting sensitivity we see here generalizes. I don't have data to back this up. This is just this vibes, I suppose. It's not obvious to me that this sort of prompting sensitivity level we see generalizes to, say, the really large commercial models that exist.
Yeah, you've already limited yourself to 70 billion, right? That's a
Exactly. And that's
small
because
number compared to commercially available ones.
you can afford to run and fine tune. So it's possible that these problems, I'm not making any claim that like if you ask open evidence something with a slightly different format that it's all of a sudden going to give you wrong answers, but it is something that's a challenge when you're doing these sorts of evaluations at the smaller scale, at least.
Well, I also noted that your prompting, and I'm guessing your system instructions are fairly short, right? Like
Yeah,
we can see in some of these prompt engineering papers, absolutely massive prompts that give huge amounts of background and context and even instructions to the model on how it should act and how it should respond. So you've kind of let the model answer to the best of its ability without drawing too many of your own conclusions and context yourself. So I think that probably goes into it, right?
I would imagine so. I mean, I think the part of what we were doing here was sort of to align with how other people had been doing these evaluations. Because we wanted to sort of paint as apples and apples a picture as we could. But I think it's certainly possible that if you give it's sort of I don't know, a double-edged sword in some sense. It's like, yes, providing very long prompts tends to help, I think, for a lot of tasks.
It just stabilizes the response in a lot of
Yes.
ways.
And I think in general, when I think about, someone coming to me and saying, I have a great new model and it's really good at X, I think of the model as being both the weights themselves and the prompt they have designed because it makes such a big difference. So for instance, it's quite possible that these numbers change quite a bit if instead of doing that sort of short zero-shot prompt, you give some big preamble of some kind. I don't know that we've tested
Well,
that.
and people underestimate the amount of memory that goes into especially commercial products, right?
Yes.
These things all have hidden memory. They all have extracted things from your previous interactions and all of these things that very much could cloud the response. So it's good to think about minimalizing in some ways to draw out the key aspects.
Consistent result. Yeah, absolutely.
If you have other questions, feel free to reach out to Michael, and I'm sure he'd be happy to give you an answer if it wasn't answered today.
Yeah, that was a wonderful presentation and great conversation. Thank you.
All right, thank you.